Okay, welcome everyone to another episode of Talking Away the Taboo. I am so thrilled to introduce actually this brand new phenomenal, okay, fine. I'm telling you it's phenomenal before even telling you what it is, whatever, it's fine. This phenomenal collaboration between I Was Supposed to Have a Baby and Jscreen. Um, JSCREEN is a wonderful national organization that really deals all with genetic screening, genetic testing to help the Jewish community at large so that we can create and build healthy Jewish families. And I have three incredible experts here today to talk about different aspects of genetic testing, genetic screening. But what this whole conversation, this is the first in a series of five different kinds of conversations about different genetic topics, all that overlap and interplay with the fertility community. And we're going to be doing that over the course of this year to really illustrate for the community at large, for all of you, that there are so many different kinds of genetic problems that exist in the world, and that each of those pieces carry their own emotional weight with them. And what we do here at I Was Supposed to Have a Baby is we hold space and we validate people's experiences and the emotions that they're dealing with as they're holding and experiencing, and now I'm using that word twice, different challenges. And so this is the first in our series, and it's really to talk about the general basics of genetic counseling, genetic testing, why someone would need any kind of genetic testing or screening. And I'm now actually going to stop talking and introduce you to our incredible panel of people who are here today. So we first have Natalie, and now I'm actually embarrassed to say this, that I don't know how to pronounce your last name. So you need to help me,
Okay,
Natalie.
pretend there are two H's, Richeimer.
Richeimer. Okay, great. Thank you. Natalie Richeimer, who is a genetic counselor at JSCREEN. Then we have Dr. Batsheva Maslow, Lerner Maslow, who is a reproductive endocrinologist. And we have Rena Fox, Blechner Fox. Did I get that pronunciation right? Did I?
Yep.
Close enough or good
Yeah.
enough? Okay.
Nope. Perfect.
Okay, perfect. Okay. So, Natalie, please tell us who you are, your relationship, your role at JSCREEN, and then we'll move through our panel and start off with Rena's story in a couple of minutes.
So my name is Natalie. I'm a board certified genetic counselor. And really my area of specialty is reproductive genetics. So people who are trying to get pregnant or are pregnant already, that's really the space and specialty that I work in. I'm currently working at JSCREEN, which is, as Aimee put, an incredible nonprofit organization nationally throughout the United States that really focuses on getting people access to affordable, high quality genetic testing. And we'll get into that in the episode. And I am their outreach and education manager. So I'm somebody whose job really is to educate the wider community about the importance of genetics and the importance of genetic testing and how it can be really, really vital to their lives. And thank you so much for having me today, Aimee.
We're thrilled to have you. Okay, Dr. Maslow, you're up.
Hi, I'm Batsheva Maslow. I'm a reproductive endocrinologist and infertility specialist. I practice at Reproductive Medicine Associates in New Jersey. I'm the lead physician at the Jersey City office. As part of my practice, I see and treat a whole host of reproductive conditions. So I see women and couples who are coming for infertility. I see fertility preservation patients, but I also, what falls under my umbrella is seeing patients who have been trying to conceive and are having pregnancy loss. And so we sort of see and treat that whole wide array. And obviously there's a lot of overlap between those conditions and various genetic topics that we're going to address today. And I'm really looking forward to the discussion.
Wonderful. Rena, I I know that your background is actually in fertility. You're a fertility nurse, which we're going to get to in a second, but you have a personal story of being a person, being a family in this community who has had to deal with a genetic issue. Your story was actually beautifully and like miraculously, I publicized in Tipora Grodko's podcast, Stories of Hope, the story of you meeting your husband. It was like so incredible. And you did speak about your genetic piece. But for those people who haven't listened to that podcast, and now I'm actually plugging it again, you all must go listen to that podcast. Rena's episode and just the general podcast. But we'd love to hear from you, your story, and how the genetic screening testing played into your like wanting to build your family.
Sure. So my husband and I both had done Jscreen actually while we were dating. We were both older singles living in Washington Heights. And I was dating and somebody's like, you really should do this. I'm like, okay, fine, I'll do it. My husband and I were friends for a while first. And when we started dating, I don't even remember what sparked the conversation, but we were both like, hey, we should probably just like compare genetics. He's like, oh, I'm only positive for one thing. I'm sure it's fine. And I'm like, let's just look. So we pull up our Jscreen results, and sure enough, we're both positive for the same disorder. And it wasn't even a disorder that we would be comfortable making a family naturally with. It was a disorder that is pretty morbid, and mortality is really low. Usually within a year of life. So we had to have a really hard conversation really early in dating, which was very awkward, but very important. And we actually broke up over it because I was just too in my head. I'm like, this is not how I wanted to make a family. This is just too much. Like the guilt I would have if we would have an accidental pregnancy with a baby with it. Like there was just so many things that I just couldn't handle at that time. But because we were friends, we stayed friends. And after dating both of us each for so many years, when you finally find a connection, it's hard to just let it go. So we got back together and we made an appointment to speak to an REI to discuss, like, is this possible? I actually had already had an appointment set up to freeze my eggs. And so I was like, hey, can we make this into like a 2-part appointment? They're like, no problem. And we were told like, it's possible. It might be hard, but it is definitely possible to do. So flash forward, we got married. I started working in a fertility clinic. I was working labor and delivery prior to that. And they're like, let's just test your AMH. Let's see what's going on. So I had my AMH tested and they're like, let's move this up a little bit. So
Can I just, Rena, can you just explain for people who don't know what AMH is, just why it needed to be moved up?
Sure. So AMH is anti-Müllerian hormone, and it's a number that is indicative of your fertility health, quote unquote. So there's certain numbers for certain age groups. Mine was on the lower end. It wasn't like alarmingly low, but it was definitely lower than they would have liked to have seen, especially since I had had my AMH drawn a year before, and it was significantly higher. So because of that large drop, they were like, we shouldn't wait too long on this. Now, AMH it's kind of, Dr. Maslow could speak more to this. It's not always like a great indicator of fertility health, but it is pretty indicative of where you stand in your fertility journey, of how many, like, of your years of fertility. I don't know if I'm explaining that 100%. But
we'll let Dr. Maslow get more into that later.
Yeah.
In the meantime, continue on.
So 3 months into our marriage, we started building probes to detect the genetic disease in our embryos. And what that meant was that we had to take DNA from ourselves. It had to be blood samples from ourselves and saliva samples from our parents. And the company was able to detect exactly where on the DNA the carrier like gene was. So this way, when they looked at each embryo, they can detect that, okay, it has gene A and gene 3, like one for me, one for my husband. That's now a carrier. So we had our probes made. That took about 2 months to be made, and we jumped right into IVF. We ended up doing 4 cycles before we had enough embryos that I was comfortable doing a transfer. Unfortunately, it was a 25% chance of an embryo having the disease, but that doesn't mean that 25% of your embryos will have it. It means each embryo has a 25% chance. So we just kept hitting unlucky numbers. And after our 4th cycle, we had 3 embryos. And we decided, okay, we're going to go forward. We're going to try a transfer. Unfortunately, the transfer did not work out. And we went into our 5th IVF cycle. And from that one, we got 2 healthy embryos. And then we did a transfer and I had my son.
Unbelievable. Unbelievable. How old is your son now?
He's 10 months.
Okay. Okay. I have so many more questions, but I think I'm going to hold them for right now because what we wanted to do with this series really is to illustrate all of the different possibilities of what someone with any kind of genetic disorder or some sort of carrier status, the way you and your husband have, what that couple, what that person would have to go through in order to be able to get to the other side of where you are now, and God willing, at one point have a baby. So thank you so much for sharing your story. I mean, again, we'll get to so many more questions, but I want to go back now and Natalie, can we first of all just discuss what is a genetic counselor? Like why are we having this discussion first? And then Dr. Maslow, then I'm going to come to you right afterwards and say, like, what is an infertility evaluation look like in regard to genetic counseling? And this, like, is Rena a typical patient? Is she not? Like, let's sort of start and open up the conversation. So Natalie, I'm coming to you first.
So a lot of people have never heard or understand what a genetic counselor does. So I'm so happy we're dealing with that first. A genetic counselor is a 2-part piece. So we're people who have specialized training in clinical genetics. And we're also, there's the counselor piece. We're also trained really in non-directive counseling and psychosocial support. So we have both of those kind of pieces. And we work with people like Dr. Maslow, we work with MFMs, we work with all sorts of different types of physicians as part of your medical team. And really our job is to give you risk assessments based on your personal and family history, as well as test results if we have them, and really help you plan for the future or understand what's coming in the future. And in terms of, a fertility journey, that can be really, really helpful in directing care. So when Rena talked about her story, right, having those genetic results really impacted how she was going to choose to build her family. And that's often a really big part of that conversation. And we work with, obviously the patient, but as well as the medical team to make sure that we're all on the same team. We're all serving our patient in the same way.
So just to like poke further for a second,
Sure.
Rena, when you got the test results from JSCREEN, and then when your husband did, and when the two of you then sat together and were like, oh, did then you reach back out to JSCREEN and say, like, I need to speak to a genetic counselor and figure out like what's going on and what we need to do? Was that sort of how it happened?
It should have been.
Before you went to your reproductive endocrinologist?
It should have been. I did not, but it should have been. I did, though, reach out. So prior to being with my husband, I was dating somebody else who had never done JSCREEN, and I had him do it. And when we got his results back, I did call JSCREEN. I was like, hey, can you just like look at these and make sure we're compatible and all that? And JSCREEN was amazing. They were so communicative. And not only when I had the results with my previous partner, when I got my own results, I still remember I was on the subway. I jumped out of the subway cart to get those results. And the counselor like went through each and every disease. Like, what's the like risk of somebody else having it? What's the rate? What's the mortality like? What are the symptoms like? Every single thing, answered all my questions. I was probably on the phone with them for a half an hour, and they were just so helpful, which that's why it should have been my first call after we found out the results. I think I was in like this state of shock that I didn't even think about it.
Look, I mean, obviously it makes sense. All of us make this, like, none of us are thinking clearly when we like get results that are different than what we expect. But okay, so now to move the conversation forward. So you then, like in your story, you then like you had this appointment already set up to do egg freezing, but then you had the second conversation of, hey, you know, by the way, while we're here, Dr. Maslow, don't you love those by the way conversations in medicine?
To be fair, I did give them a heads up.
Okay, so Dr. Maslow, what someone like Rena and her husband, or her, I guess, what is it, your
He was
fiance
my
at the
boyfriend at
time.
the time.
Boyfriend, fiance at the time, you know, someone coming into you with a known genetic issue, what is then your next step?
Okay, so I'm going to take one step back and say this is, first of all, it's not, you know, it's a very special story, and I really appreciate that you shared it, Rena. And it's always nice to hear the success stories, but you know, and also the journey that it took to get there. And it is something that is, you know, where I'm seeing more frequently and comes into my practice with some regular basis. Either a couple who knows in advance, and in the Jewish community, we're very comfortable with genetic screening. It's something that is we're all sort of brought up with. Not uncommon that I'll have couples who have had a very similar experience to Rena, and you know, probably not the exact same diagnosis, but they carry some, you know, they carry a joint mutation. They knew about it in advance. They went through probably a lot of the same sort of emotional phases that you went through, and they kind of end up in my office exactly the way you ended up in your REI's office. And then sometimes it happens in a different pathway. Sometimes it's a couple who unfortunately has a child with a condition and then finds out that they're both carriers, and now they're in my office to talk about having a second child, or they had a pregnancy that was affected by it. You know, so they only learn about it later. And then the third way that we have these conversations is that I basically offer and encourage genetic screening for essentially every couple who's going to go through IVF. Because even if we don't know that you are a carrier, the last thing I want to do is end up with the fact that I had embryos in my lab that I could have tested, but didn't because I didn't know about it. And so pretty much, you know, nearly 100% of my patients who are going to go through IVF, if they haven't had genetic screening already, are going to get it. So those are sort of the three pathways that people end up in front of me talking about this process of genetic testing for the embryos.
Can I actually ask you one more question and poke you a little bit more? Isn't it also the case that another scenario could be people who have recurrent pregnancy loss and they're potentially looking for a genetic reason, and that might be another reason why they end up in your office?
For sure. So in the world of pregnancy loss, just to take a quick detour to talk about that for 1 second. So in the world of pregnancy loss, there's kind of three bins that we think about in terms of the potential causes for pregnancy loss. The vast majority of the time, we actually never find a reason for pregnancy loss. But one big reason is some kind of genetic situation that is affecting the fetus, whether that's a genetic condition in the fetus itself that is spontaneous and unrelated to the parents, or something that the parent, one or both of the parents, is passing along to the fetus. Now, that can be in the form of what's called a balanced translocation, which is different than the mutations or the individual gene mutations that we might be referring to, or that Rena is probably alluding to. But a balanced translocation is where two portions of DNA, or two portions of the chromosome, are abnormally attached to one another, so that the parent who has that translocation is totally normal. They have all the normal DNA. They function as a totally healthy adult. But when they go to make gametes, when they make eggs or sperm, and if you remember back to meiosis and mitosis from like 9th grade biology, those DNA have to split. And if it's abnormally attached to one another, you will get uneven splitting. And so you have eggs or sperm that have an abnormal number of chromosomes, and that will lead to a situation in which that person is at risk for having multiple miscarriages, because those unbalanced either eggs or sperm will lead to unbalanced embryos and will lead to miscarriage. So I've diagnosed that in patients who have come to me with miscarriage, and I'm like, oh, actually, I found out what's going on, and there's a relatively quote unquote easy fix, is that we're going to do IVF to identify this translocation. I've actually had it where I diagnosed it in one couple, and he said, my sister just had a miscarriage, and I saw his sister and diagnosed it with her too.
Wow.
Right. So we've had, it affects families in a profound way, and really can alter sort of the trajectory of this. And when we, in that particular situation, they actually then found out that their parents, right, they inherited it from one of their parents. I don't remember which one, but their parents had actually, even though they had a very large family and had multiple siblings, their parents had actually had many miscarriages in between, and they just didn't know. And so we actually really sort of were able to alter the kind of trajectory of their, of their reproductive life in that way. And then sometimes, rarely, very rarely, recurrent losses can be a result of, a genetic mutation that both parents carry. And so if in patients who have come to me with losses, if they have not had genetic screening, like the kind that Jscreen offers, that's also part of my kind of initial workup.
As someone, many of the people in the I Was Supposed to Have a Baby audience know this, but as someone who personally had many miscarriages, genetic screening and genetic testing, I really should say, was really a significant part of our workup. We ended up not finding anything, but we went down the rabbit hole of like lots of different places where we got genetic testing, including Jscreen, but that's a story for another time. Okay, let's now sort of, I'm sorry, I'm like getting beeped all over the place. I will cut this part out. I don't know if anyone can hear it, and it might not come up in the recording, but we'll cut that part out afterwards. Okay, let me just note this down. Okay. So to continue, Dr. Maslow, so can you like go back and sort of, we were talking about the sort of general reason how genetics like interplay with a fertility evaluation. But my question to you is that a lot of people will end up in, your office beyond the reasons that you described. They'll end up in your office because like they just think like that they're older and that their eggs or their sperm, like things are just not working out well. And it must be that there's some defect with either one or the other. And like, it's not always the case that someone who's older is going to have a genetic problem, or will they? I guess that's kind of my question.
I think it's a good question, and I want to clarify. So we're talking, there's sort of, when we say genetics as like a large umbrella, in my world, there's actually sort of two elements to that. There's the genetics of the parent or the couple, the patient, right? The male and female who are trying to reproduce. They have their own set of DNA. Those DNA have, mutations, like we all carry something. But by and large, they're obviously like healthy, functional adults. When we talk about pregnancies and pregnancy loss, so the most common reason for pregnancy loss, and likely really the most common reason for infertility, is that as we get older, chromosomal errors start to accumulate in our eggs. And it happens in sperm too, although it is much more pronounced in eggs. So women are born with all the eggs we'll ever have. Eventually, as we age, not only do we lose our eggs, so Rena mentioned AMH. AMH is a marker, an indirect marker of overall egg supply. So as women get older, their AMH will generally decline because the supply of eggs goes down, and we use it mostly in IVF and egg freezing, for example, as a way to kind of estimate what are realistic expectations for how many number of eggs we can retrieve. And when we start talking about these, where we're genetic testing embryos, like the numbers, it becomes a big numbers game, and we'll get to that, later. But as the eggs age, so not only do the number of eggs decline, but these chromosomal errors, extra chromosomes or chromosomal deletions, either complete or partial, start to accumulate in the eggs. And so the eggs become less likely to lead to a healthy baby. So the most common reason that an embryo, once it's fertilized, whether it's fertilized in the body or in our IVF lab, the most common reason that it won't work, it won't implant, it won't grow, or it will end as an early miscarriage is one of these chromosomal abnormalities. And so that becomes a big part of the conversation in women as they age. And age is like the number 1, 2, 3, 4, maybe more biggest variable when we talk about what's the likelihood of success with egg freezing, with IVF, with genetic testing, all of that. So much of it ends up coming down to age, partially because we're talking about numbers, and the younger you are, the higher the number of eggs we're going to get, and the higher chances that any one of those eggs could go on to produce a viable pregnancy. And so when we talk about testing the genetics of an embryo in the lab, there's actually 2 types of genetic testing that we do. And I just want to give you sort of the nomenclature, because when you read about it and you hear about it, there's really 2 different nomenclatures. We call it pre-implantation genetic testing, or PGT. And the first is PGT-A, which the A stands for aneuploidy. Aneuploidy is like the scientific word for having an abnormal number of chromosomes. And so PGT-A is kind of a genetic screening for embryos that's offered to everyone. In my office, we do it almost routinely now, because what it does is it allows us to identify, you have 4 embryos available, but actually embryo number 1 and embryo number 3 are abnormal and will never work. We're not even going to use those. We're going to go to the ones that we know are going to be most likely to be successful. So it screens out things like Down syndrome, Turner syndrome, other types of chromosomal abnormalities that become more common as women get older. That's PGT-A. And additionally, there's something called PGT-M, which the M stands for mutation. So in a situation like what Rena was describing, if we have a patient who is a carrier, where both partners are carriers for a particular mutation, in addition to identifying embryos that have all the right number of chromosomes, that's sort of like the forest. And then you zoom into the tree, you're talking about, DNA, for those who aren't that familiar, chromosomes have hundreds of thousands or millions of DNA base pairs. And when we're talking about mutation, sometimes we're talking about like a single mutation, a single base pair error, right? So we're zooming in to like a leaf on a tree. And so that's where those probes that Rena mentioned, they're special DNA tags to identify, is that mutation present or is it absent? And it has to be built specifically to the couple that is wanting to utilize them. Because we look not only at the specific mutation, but at genes that are adjacent to that mutation, in order to really be sure that if the computer and the test is reading a negative result, meaning it said it does not see the mutation there, that it actually didn't see the mutation and not that it just missed it, right? So if it says, okay, we have genes number 1, 2, and 3, and the mutation is in gene number 2, and it's absent in gene number 2, but I got good reads on gene number 1 and gene number 3, then I know that we got a good connection on that result. So the probes take time, and as Rena mentioned, like it can take a few weeks, sometimes a few months, depending on the probe and the situation. But that's a secondary test that's done in addition to PGT-A. And then for the balanced translocation that I mentioned, it's something called PGTR, which is similar, PGTSR, sorry, which stands for segmental. So it is similar to PGT-M in that it's looking for something specific, but it's not as tiny. So it's the kind of mechanics of how the test is run are a little bit different. But it's more of a secondary test as well. So that's kind of the broad introduction to genetic screening and infertility.
That was super helpful. And I think like for people out there that like, when people just say this, like, oh yeah, like we had our embryos tested, like you see, like tested can mean a million different things, as Dr. Maslow just described. Okay, look, and I was supposed to have a baby. We deal with the emotions, and we talk all about like how difficult it is that people's experience people's longing for family, for trying to build their family, to wanting to have a baby, that longing is so hard because they see everyone else around them who is just like, having fun on a Thursday night. And 9 months later, I was just discussing this with Natalie earlier. 9 months later, they have a baby. And that's not the way it works in this world. So I'm really wondering if each of you could just speak about the emotions that couples are going through in this when they either they know that they have some kind of known genetic issue, or whether it's something that they realize once they've done some of the testing, and how each of you in your different roles, and Rena, I'm going to come to you at the end, like with your experience specifically, but how you help people through this idea that things are not they're not going to work out the way that they planned, and knowing that they have something that's going to cause a problem, or already has caused a problem. Natalie, I'm going to come to you first.
Yeah, I would say, things with genetics are very emotional. I think when we talk about people who come through my office, sometimes it's people who've never had kids, and sometimes it's people who've had losses or have had a child that has passed. And so for the people who've had a child that has passed, or a child that is currently, living but with a significant disability or significant illness, there's a lot of guilt that the parents have that we have to work through. Like, how did I do this to my child? And there's a lot of pain with that. And, a big part of what we do, as genetic counselors is really to normalize, right? Like, none of us would want to harm our children. This is not something you did intentionally to harm your child. This is something you passed on, without knowing, right? And we all have things that we pass on to our kids. So I think it's really, really important to normalize, just like Dr. Maslow was saying, that there are so many people who pass things on to their kids. Some are genetic disorders, some is a predisposition to having diabetes or heart disease, right? Nobody's not passing something on to their child. So normalizing is a really big part for us. I think, the people who come to me with recurrent pregnancy loss or have had a stillbirth, there's a lot of pain, and, it's a desperate need a lot of the time just for answers, right? Like, why is this happening? I just want to know. And genetic testing can feel really, really helpful in getting people the answer of, like, there is a reason, or there's just a reason that we don't know, but we've turned over all the stones that we can. And, we feel comfortable moving forward, going to someone like Dr. Maslow now for our next steps, because we feel like we have that. I think the emotional journey of finding out you were a carrier couple is something different. Like, everyone in genetics is kind of different, but people will find this out. I would say, like, I don't like to use the word incidentally because it's not the right word, but, like, it's just not what they're expecting. They're expecting their carrier screening is going to come back negative and everything's going to be great. And especially in, like, the Orthodox world, where it's much more common to do this, like Rena was saying, even before marriage, no one thinks they're going to be that one with the positive testing. No one thinks, and we do cancer genetic testing as well for hereditary cancer. No one thinks they're going to be the one to get, the positive mutation for, a gene associated with hereditary cancer. And when they do, there's, like, a real shock and a real grieving process that happens. And we're there to support them. We're there to connect them with other people. A lot of the people coming to me are sometimes really debating. I mean, the slew of recessive conditions or X-linked conditions, it's very variable. You have conditions that are really typically life-limiting, things like Tay-Sachs, right? And you have certain conditions that are much more mild that people can live with. So a lot of times the conversations with me are, should I be doing IVF? What does a baby's life look like, with this condition? And talking and, connecting people with other moms, or other families who've had a child with this condition. So there's a lot of support aspects, but I think my most important job, is really giving people good information so that they can make decisions that feel good for them. There are people who, for whatever reason, will never want to do IVF, and that's okay. And giving them other options of, like, you want to go through a pregnancy naturally. What is that going to look like? What are some diagnostic options that we can offer you through a pregnancy? What are some options if you want to just test baby after birth? And what does that look like? And how can we get you connected with people? So really offering them really good information. And then like going over the risk results, I think is so helpful as well. A lot of people who come to us think that the chances of them, giving their baby a genetic condition are like 100%. And with recessive conditions, we're often talking about 25%. That feels a lot better to people. And 25% is a real number. I'm not taking that away. But I think sitting down and really going through, okay, so here are the stats. These are what the numbers look like. I think are important. Same thing with like, sometimes the conversations like Dr. Maslow was mentioning about things like balanced translocations or inversions. Those are trickier conversations, but really giving people the numbers so they can feel empowered to then choose their next steps in their journey is a huge part of what we do. As genetic counselors, and it's a huge passion of mine. And like you were saying, Aimee, like the emotions, they're there, and so sometimes people are going to meet with me once, and sometimes it needs to be a little more.
I love the way you took us through all of the different pieces and the aspects. It's so important for people to understand and to have the support of a genetic counselor as they're going through this. Dr. Maslow, what happens? I mean, people are coming to you for answers. I mean, in a similar way, obviously, as a genetic counselor, but they're coming to you for answers, and they're coming to you and expecting you to give them the solution. And then what happens in that process for you? Like, how do you
Yeah.
balance the medical and the emotional?
So I will say, I mean, a lot of what the emotional sort of hand holding that I do is a lot of what Rena described it really well. Sort of taking people through the fact that this is not the way I expected to grow my family, right? There is a grieving process that has to happen. And sometimes it's very different than the couples who are experiencing infertility, right? The couples who are experiencing infertility have been in this, for a year, sometimes more, right? So they're already that grieving happens relatively slowly, and by the time they get to me, they're like, okay, I'm going to do whatever it takes. And so it's a little bit of a different process where it's like, oh, I didn't realize I wouldn't be able to have a family, in a typical way. And not only that, like, I'm not even going to get the opportunity to try. And so that is there's a lot of emotion there. Um, but unlike some of the other more difficult medical scenarios that I find myself in with patients, there is a very tidy solution to this. It's difficult and challenging, like, not to belittle what it takes to go through IVF. And like Rena said, it doesn't always work the first time. It doesn't always get us where we want to go. But this is not a scenario where 20 years ago, we would have been like, I'm sorry, there's nothing we can do. And now we have the opportunity to say, okay, actually, there is something proactively we can do to try to prevent you from having what will likely be could be a much more painful situation. And so I really try to help patients focus on, what the proactiveness of it. I think Natalie really highlighted that having the knowledge is very empowering. And, knowing, as painful as it is to know, knowing is usually 1,000 times better than not knowing. And so those are the things we really try to focus on. And thank God we live at a time where, the technology, it's not perfect. Would I like it to be better? Absolutely. But it is, for many people, a wonderful solution. And I know we often hear about the hardship and the difficulties, and they are there, but there are also lots and lots of wonderful success stories of healthy, beautiful families that may not have otherwise been possible. And I can't even, it's like more than I can count on. I can give you so many like wonderful examples. And it's actually part of like a very satisfying part of my career, because it is something where it's like, okay, there's a problem, and I know what we need to do to fix it. I don't know exactly how long it's going to take and how easy or hard it's going to be, but I know what it takes to fix it. And that can be very gratifying. And it's nice also when sometimes it goes smoothly, and a little smoother than Rena's. For many, it does go more smoothly than that, but it is just very nice, and it allows people to really go through the next phases in their family building journeys without having to sort of really worry about some of these really complex, scenarios.
Look, 1,000% right. Like, we are living in a time of medical miracle, and like, it is absolutely remarkable that yes, you have this sort of tidy fix, and yet there is still so much hand holding that all of
Yeah.
us need to have in this process.
Yeah, not to belittle the process
Yeah.
at all. It's a process. Absolutely. It is a journey. And, I think everybody at certain phases in their lives, there are chapters, and some people's reproductive chapter is very simple and they have other challenges that they face. And some people, their reproductive chapter is going to be their most challenging chapter. And so, yes, it is definitely challenging, but it is, of the things that I work with, one of the ones that is more gratifying to help people through, because there is options now.
Absolutely. Absolutely. Rena, I'm curious, you just heard the two of them speak about, from their perspective, the professionals in in this world, on how they're trying to hold their patients. For you, I mean, you talked about the different pieces sort of matter of factly with a little bit of emotion there. I'm curious if you could just give a little bit more light to some of the emotional pieces that you went through in your journey.
Yeah, so when we first found out, there was a lot of tears shed after dating for so long, finding a connection with somebody, and then finding out that we're both positive for this horrible disease and what that would look like, and mourning the relationship, and then mourning, well, if we do stay together, mourning the loss of what I thought my reproductive future would look like. Nobody grows up thinking that I want to do IVF. Everybody wants to be able, like you said, have fun on a Thursday night. And it's not just that, okay, now we have to do IVF. It's now we have to be careful for the rest of our lives. Now that option is taken away from us. So that part was very difficult. And it's something that still struggle with. I still struggle with the fact that we were never even given the chance to try on our own, because it was just too dangerous for us to try on our own. So that's something that is going to probably be a lifelong battle for me. And every time we went through a cycle, it was like, I wish we could have just done this on our own. Why do we have to do this? This is so frustrating. It took us, there was a lot of then battle also with like your inner self and with spiritual, and of we waited so long to find each other and now we have to go through this. It's so unfair. And there was definitely times where I wanted to just give up, and I was like, well, how do I know if I even want a family? My whole life I was told you're going to have children. Of course you're going to have children. Do I even want children now? And definitely don't feel that anymore. My son is like my everything, and I love being a mom. But you really go into questioning things when you failure after failure after failure, and it's so hard. And as a woman, you feel like, well, this is what I'm supposed to do. I'm supposed to be able to have children. Why isn't this working? It's so emotional. So many tears were shed. It was just, yeah, I mean, we made it out the other side, but it was not easy.
Aimee, you're mute.
I'm so sorry that you went through all of that. I mean, it's like, I hear from people a lot, this idea that like my fertility journey should be easy because like it took me so long to find someone. And then when you have this like double whammy, as you just like described, like isn't anything going to be easy here? Like, well, how come? And there are no answers, right? None of us have any answers to this. I'm just curious about one more point, Rena, as we close here. You the other piece of this is the idea that it's not only that you didn't have control and that you weren't able to sort of try naturally just like everyone else, but also in the midst of like going down this path, you also like didn't get the number of embryos that you wanted to get right away, and so you had to go through multiple cycles. And like I think I'm curious if you could just speak to that piece also, because people assume, at least I know from where I sit, people assume that, oh, you have a genetic issue, Great. So that just means you'll just do IVF and you'll just do the genetic testing and then everything will be fine. And so just share a little bit about that piece, please.
Yeah, that's what we thought. We went in thinking it'd be one cycle, we get our embryos, and then we'll transfer them when we're ready to transfer them. We never in a million years thought it would take 5 cycles to get our son. It's a numbers game. Unfortunately, the number is not the generalized number, it's per embryo number, and it's luck. We just keep saying that we had really poor luck. But also we feel that if we had to go through all of this and 5 cycles and 2 of those cycles produced nothing for us, to help others, then that's like our portion in life. And we're happy to be able to provide that support. But it's really hard. I went in thinking it was going to be a 1 cycle and that's it. Here I am, 2 months married, going in for my first retrieval. We had such high hopes. I bought a onesie. I was so confident that it was going to work. I bought a onesie that said something about like IVF on it. And I had to give to my husband to show him we were pregnant. And it sat hidden in our second bedroom closet for 1.5 years until I could give it to him. But I was so confident that that was it. It was going to be 1 cycle. I was going to get pregnant and that was going to be our family. But God had other ways.
We so many things we don't understand, right? We just don't understand. Okay, as we close this down here, and I really just want to thank all of you for sharing your experiences and your expertise. I'd love to just hear, I'm sure we missed 1,000 things that we could have talked about if we had, 1 million more hours. But if there's one thing that you want to share with this audience about your experience or about your expertise here, I'd love to hear it. Dr. Maslow, I'm going to come to you first.
Okay, perfect. Thank you. So I want to just touch and kind of dovetail what Rena's saying. And, one of the things that can be, challenging, especially like IVF is so wonderful and it has done so much and is, thank God, so successful, but it doesn't always go the way we expected and doesn't always go the way we planned. And I mentioned earlier, like age has become such a huge factor because it has such a major impact on the number of eggs that we retrieve and the likelihood that those eggs are going to be successful. And then when you add an additional layer that some percentage of those embryos, even if they're perfect genetically from a chromosome standpoint, are going to have some other issue that you are not going to use them, you're going to drop that even further. And so there have been, some papers, and now it's coming out much more about really emphasizing how important it is to be proactive and doing this at as early an age as possible. So much so, for example, I wrote an article that was published in an oncology journal several years ago with some colleagues about women or even men truly who carry the BRCA gene. Now, this is a totally different scenario, but it's what we call autosomal dominant. So that you carry this mutation, it puts you at risk for potentially developing cancer. Now there are opportunities where we could test embryos for the BRCA gene. And I don't want to get into the ins and outs of that, but
that is another podcast. It's another series.
Podcast.
We will get there.
I'm using that as an example because what happens is that if you carry this mutation that you may one day want to test your embryos for, if you have a partner, you want to start working on that as early as possible. And if you don't have a partner, you want to think about egg freezing as early as possible. And Rena brought up egg freezing. Now, without knowing, in Rena's situation and other situations like that, if you didn't have a partner and you didn't know what the partner's testing was, you wouldn't necessarily think you're at risk for passing along a genetic disease. But if you know that you are at risk for passing along a genetic disease, there are things that people know in advance. How it is, I can't emphasize enough how important it is to try and get at this as early as possible. And even when it's the male partner who carries the disorder, getting the embryos or the eggs of his female partner before she gets older, just increases your chances even more. And there was just a research study that came out recently, and I actually haven't had a chance to review the data, but shows sort of how precipitously the chances of getting a both chromosomally and mutation healthy embryo, how precipitously that drops with age. So not to be doom and gloom for those who are older, but really that, and we talked about some of the emotions to it. So much of the time, the instinct is like, I don't want to deal with this right now. I don't want to talk about it. I don't want to think about it. And I really praise Rena's team for sort of encouraging her to move ahead with this earlier based on those AMH numbers. Again, AMH isn't the end all and be all, isn't everything, but it can help kind of color these conversations and understand sort of how proactive do we need to be? How fast do we need to do this? But I cannot overemphasize how different the results can be between somebody in their early 30s compared to their late 30s. Not that someone in their late 30s shouldn't do it, but if you have the opportunity to do it earlier, it's going to be all the better. And it's just really important. And, you know, we can talk about other scenarios. BRCA has its own unique scenarios that involve, you know, potentially removing ovaries in the future. But that, you know, to me, that's like the one piece of advice is that if you know that you may be at risk for passing along something, or you know that for whatever reason you're going to be doing genetic testing for something specific, not the genetic screening we talked about, but for something specific, that the sooner you sort of get on top of that, the better your chances are going to be.
Thank you. That, again, like to crystallize it down to, I don't know, one sentence, early is better than late, right? Did I get that right?
Yeah.
Okay, perfect. Not to say that you shouldn't listen to everything Dr. Maslow just said, because every word is gold, but take home message, get it done earlier. Rena, are you around? You can talk just in the car. Okay. Do you
Can
want to
you
give
hear
us
me?
Yes.
Okay, perfect. I wasn't sure if you'd be able to hear me.
Perfect. Okay. Rena, I'd love for you to share your closing remarks.
Yeah, so like Dr. Maslow was saying, it is really important to do this young. I had my consult to freeze my eggs at 30. Everybody thought I was crazy to do it at 30, but then a year later, my AMH dropped. So I probably would have been better off to freeze my eggs while my husband and I were dating. That being said, like I didn't, and we had to go through. Truth is, with my cycles, like I always got enough eggs. It was more the genetic component for us, but it is important to do it early. And I think the most important thing is to just know, like, you're not alone in this. If you do find out that the person you're dating or you're married to is positive for the same genetic disorder, there are options out there and there is support out there. Nobody needs to like hide behind a stigma and feel that they're all alone. There's so much out there to help support people.
Absolutely. Absolutely. Natalie.
I would say everything that, Rena said and Dr. Maslow said, of course. We didn't talk about it so much, and Dr. Aimee will talk about this in other episodes, but family history is a huge part of the puzzle. Genetics has a lot of different pieces to it. So genetic testing is really huge, but making sure that you're gathering your family history as well, both your personal and, from your paternal and maternal side is really, really important. And to know about all your options and making sure that you're really getting the information that you need to feel comfortable in your journey is so important. And really just making sure to utilize every single person on your team. If you're in the fertility space, you have great access to people like Dr. Maslow. You have great access to things like I Was Supposed to Have a Baby, which is an incredible support organization. You have great genetic counselors. So make sure that we're all working with you and making sure that you're getting the most out of your journey.
Thank you so much. Look, absolutely. Everything that Natalie said is correct. And I'm echoing also Rena's sentiments. You are not alone. All of you out there who are listening to this, who may have something that you know about, or maybe it's not anything that you specifically have, but it could be someone that you love has. The reality is that There is so much support out there, and we are all here at I Was Supposed to Have a Baby, but all of these different resources, you can reach out to any of our speakers. We'll put their contact information in the show notes. But this is our series, the beginning of our series, to talk about these kinds of issues, letting you know that you're not alone, letting you know that there are people here waiting to hold your hand all the way through the process. Um, Thank you so much for being a part of this, for learning and listening, and knowing that you will be supported through whatever you are going through.